Then we have our next speaker, Dr. Srawani Sarkar, talking on proptosis in young female and its association with high ASO titer. And we request the next speaker, Dr. Shilpa, to please be ready because we have a lot of speakers and I don't know if we have enough time.
Good morning, everyone. I'm Dr. Srawani, and I'm be presenting a study on this proptosis in a young female and its association with high ASO titer. Our patient is a 13-year-old female who presented with proptosis of the right eye since 15 days, but insidious in onset and gradually progressive, associated with dimness of vision in the right eye. There was no recent history of fever and no history of trauma. In medical history, there was no history of autoimmune disease. There was history of sore throat and fever 4 months back. In the family history, there was no history of any autoimmune diseases. This is a picture of the patient where we can see right eye is proptosed. Visual acuity was 618 in the right eye, whereas it was normal in the left eye. On external examination, there was proptosis with Hertel's exophthalmometer. The measurement of protrusion came around 24 millimeters, while on the left side it was 21. In the lid, there was mild ptosis present. The rest of the examination were within normal limit. Ocular motility, it was restricted in the right eye, laterally, temporally, superior-nasally, as well as superiorly, whereas it was normal in the left eye. Fundus examination, disc edematous with a blurred disc margin on the right side. Investigations, all routine blood investigations like RBS, CBC, CRP, ESR, LFT, KFT, everything, and thyroid profile was done, which was within normal limit. ASO titer was high, which was 563 international units per ml. On USG-B scan, there was proptosis of the right eye, and there was heterogeneously enhancing ill-defined soft tissue lesion in the right orbital apex, extended into the intracorneal compartment with encasing the optic nerve and the superior rectus muscle with associated fast stranding. MRI orbit was also done, which showed similar finding of proptosis and ill-defined heterogeneously enhancing lesion with high signal intensity seen involving the retrobulbar fat, both intracolon and extracolon. Extraocular muscles were involved, lacrimal gland and soft tissue of the preseptal compartment of the right orbit. There was medial displacement and compression of the optic nerve. Based on the investigations, we arrived at the diagnosis of orbital pseudotumor or idiopathic orbital inflammatory syndrome. Patient was started on injection dexamethasone 4 mg IM BD for 7 days, after which it was tapered. Injection ceftriaxone was also started 200 mg IV BD for 7 days, and eye drop moxifloxacin 1 drop 6 times daily was started. After 2 days, there was significant improvement in the proptosis and vision improved to 6/9 in the right eye. And after 1 week, there was complete resolution of the proptosis and vision. Based on our findings, we looked into some of the studies which also had, patients had orbital myositis associated with history of streptococcal pharyngitis. Discussion. Although causes of orbital pseudotumor is often unknown, it is commonly associated with autoimmune disorders, but in our case, it was not there. Few studies have shown instances of orbital myositis associated with streptococcal pharyngitis, particularly in pediatric age group. Immune-mediated post-streptococcal inflammation of the ocular muscles could be one of the causes. In our case, there was also compression of the optic nerve, leading to diminution of vision. Thank you. And injection dexamethasone was started.
And you've investigated for thyroid?
Yes, ma'am.